Good afternoon, everyone. Dr. Gregory Boyce here, and I'm just like to welcome you on this, at least very rainy in Port of Spain, slightly thundery and lightningy and end of the worldy afternoon in Port of Spain. Thank you for coming to join us. This is our 56th session of Mrftt HIV STI Echo. I will be your facilitator this afternoon, ably assisted by the best of the best, Conrad Mitchell. Again, thank you for taking time off your busy schedules to join us today to talk a little bit about HIV prevention. Just an overview of some of the most recent developments with respect to the new recent WHO guidelines and some of the other information coming out from other research sites. So when I was preparing this, it was a bit difficult to try to figure out how to squish it down into 15 minutes because it didn't want to be a full treatise on prevention, because that's a very long, multiple episode talk. So I just essentially tried to distill it down to some points I thought that would be of interest and some of the newer research that came out with respect to approaches to HIV prevention. So we'll get started briefly, assuming the technology agrees with us. Let's hope for the best. All right, here we go. So just a brief acknowledgement of the support that we got from the Caribbean HIV Echo in Jamaica to set up this instance at Mrftt at Port of Spain, as well as the continuing ongoing support we get from the University of New Mexico School of Medicine, who founded the ECHO program. I have no conflicts of interest in relation to this presentation. So the learning objectives are going to be fairly simple. We're going to talk about the importance of HIV prevention in stemming the HIV/AIDS pandemic. And we're going to describe just a couple of recent updates to HIV prevention methods. So by way of overview, where are we, at least at the end of 2020, when UNAIDS would have published the most recent fact sheet? So there are 37.7 million persons roughly living with HIV in 2020, of whom 84%, give or take, are aware of their status. What that means is that there are over 6 million people all over the world who are living with HIV and are unaware of it, right, who have not accessed testing. And just 53% are women and girls, and they represent, in much of the world, the fastest growing group of persons with HIV. And that's due to many issues with respect to gender and structural limitations and stigma and discrimination, all of which impinge on the ability of young women and girls with HIV access prevention methods. So 27.5 million people were accessing antiretroviral therapy in 2020. That was just about 70%, which is below where we were hoping to be at the end of 2020, given the 1990 targets. It also means that between 1 and 2 million, averaging 1.5 million persons became newly infected with HIV in 2020. And this is kind of where the rubber meets the road in terms of prevention. How do we turn the tap off on that constant flow of persons with HIV? What do we need to do? What tools do we need to access and to disseminate to prevent those over 1 million people becoming infected every year? Now, the chart on the left or the image on the left, sorry, comes from at the end of 2019, the avert.org people actually made an infographic regarding what has been the changes in number of new infections over the decade. And it's generally good news. If you notice, most areas there's been a decline in new HIV infections over the decade. Global average is down 23%. But there are places in the globe where there is where some of the initial gains have been lost. So, for example, Latin America, over the last decade, they now have 21% increase with HIV. In the Middle East, North Africa, it's up again at 22%. In certain parts of Eastern Europe and Central Asia, where for various reasons, including instability and discrimination and poor systems, it's as high as 72% increase over the decade, which is really alarming when you consider after 4 decades of the pandemic that we still sort of claw back some of those gains that we would have made initially. So let's talk about what the global goals and global goal setting and global target setting means. So we all know about the 90-90-90 targets, right? 90% of persons with HIV are aware of their status. 90% of those are enrolled in care, are on antiretroviral treatment, and 90% are virally suppressed. We didn't quite get there at the end of 2020, and we're looking forward to 2030, by which time we've upped the figures to 95. We're hoping to get the number of infections down to 200,000. Remember, at the end of 2020, the 2020 goal was 500,000. We were at over 1.7 million in 2019 and 1.5 million in 2020. So we're triple where we should be, right? So we have an interim target at the end of 2025, which is that central circle that that UNAIDS would have put out when they rolled out the new consolidated guidelines in July of this year, where people living with HIV and communities at risk are the center of what we do. And there are 6 95 targets. So the 3 treatment ones, right? And then 95% coverage of services for women, so to prevent physical transmission, that 95% of women who have sexual and reproductive health services, and that top 95%, that 95% of persons at risk have access to combination prevention. That's what we're going to focus on, at least in part, during the rest of the talk this afternoon. So when we talk about combination HIV prevention, what do we mean? So based on the WHO 2021 consolidated guidelines, it's a mix of evidence-based biomedical, behavioral, and structural interventions to meet the current HIV prevention needs of individuals and communities. And each one of those 3 areas, I think, as I say, can be an hour-long talk on its own. And we're going to focus just on the biomedical aspects for the purposes of the conversation today. But we just to touch on it briefly, those behavioral interventions that we have on a one-to-one basis when in front of a patient and having a conversation about how to reduce their risk, about reducing partners, about avoiding risky behaviors, about things like substance abuse. We may put them at greater risk of engaging in activities that may expose them to HIV at the Mrftt, because all our patients are already living with HIV. There's a slightly different conversation about how do they, avoid coming in contact with STIs. I know some of the QPCC staff sometimes come in and share time with us, so they would be more on the cutting edge of that conversation. When someone comes in, for example, I remember very clearly a case, a young man, and I keep referencing him so I owe him royalties, in his 20s, who over the course of a few years had 5 episodes of gonorrhea, and despite all the conversations about partner reduction, condom use, all of that, we weren't quite able to get through to him, which is why that combination approach is so important, because not every person who come across is in a position where they'll be able to hear us when we talk to them about condoms. We can be able to hear us when we talk about partner reduction. So what tools can we use to prevent this person from becoming infected with HIV? And in addition, the combination approach mobilizes sort of all of society approach in terms of coming to the assistance of persons to keep them away from HIV infection. So whether it's communities, civil society, non-governmental organizations, faith-based organizations, private sector, government, global resources. So for example, donor groups, donor agencies, to have a coordinated, well-funded, sustainable approach to HIV prevention. And as the previous diagram would have shown, all our prevention efforts must be patient-centric, must be acceptable, right? Must be culturally appropriate, and must also match the HIV epidemiology in the country where we are. So in many countries, the epidemic is driven primarily by men who have sex with men, with a much lesser contribution from heterosexuals and that sort of thing. In other countries, it's the other way around. So how do we ensure that we match the prevention efforts to both the epidemiology as well as the groups that need it the most. Because even though those groups may not be the majority of new infections, marginalized groups who are most at risk, who are most vulnerable, may need a disproportionate amount of resources given the relative contribution to the epidemic because of the concentration of HIV in that community. And I just want to highlight those 5 HIV prevention pillars that, again, is coming from, I think, 2016 guidelines, where it speaks to programs, the first pillar, programs for young women, adolescent girls, and their partners. Second, key population services in all countries, and that references what I was speaking to about with respect to marginalized and most at-risk groups. Strengthen national condom programs. I'm going to talk a little bit about condoms, even though it's not technically new, but I think one of the concerns I've had over time is that how strategic are we in terms of our condom program in not just nationally, but in our own in our own treatment facilities, for example? Can we have a condom program at MRF? Are we monitoring, who's getting it and how are they using it, and are they still coming up with STIs, and who's falling through the cracks? And is it sufficient just to hand out condoms and not do anything more than that, right? Voluntary male circumcision, again, in priority areas. So that's another, I was kind of in two minds as to whether not to include it in the presentation. I chose not to, because it's not very widely used in our country, if at all, as a prevention tool. And that may be mostly a cultural thing. So I know we have persons from HACU and NACC, so I'll be very interested in their own experience when these sort of recommendations came around, how our country at a national level had had that conversation with funding agencies and donor groups and so forth. And finally, pre-exposure prophylaxis for groups at higher risk of HIV infection. And most of the remaining conversation is going to talk about pre-exposure prophylaxis, primarily because that's where a lot of the new technology and the new approaches have been over the last, let's say, year or two. Again, and it's an ongoing conversation in this country about PrEP programs and should we have one, and will we ever activate ours? And we knew quite well the position of the government with respect to pre-exposure prophylaxis and their concerns. So we just have a brief conversation about where a lot of the region, where a lot of the developing world and developed world is going with respect to pre-exposure prophylaxis. So just to touch briefly on condom use, because again, it's a simple tool, but perhaps not deployed to its fullest extent. So male condoms, along with appropriate condom appropriate lubrication, for example, and this is from the WHO figures, reduced risk of heterosexual transmission by 80%. Other research cites north of 90% in terms of its ability to reduce risk of HIV transmission in heterosexual sex. Risk when it comes to risk reduction in anal sex is closer to 64%. Again, based on these figures cited in WHO guidelines. With female condoms, the data is less robust, but there are references that cite up to 95% efficacy. But there have been multiple papers that demonstrate that female condoms are less accepted both by men and by women. And condoms in general, because there's so much gender dynamics and power roles and ability to negotiate condom use, again, among young women and girls who are at a disproportionate risk of HIV acquisition globally, it impacts how condoms can be deployed and how they can be used. For instance, in some societies, if one presents with partner with a condom, it may trigger very adverse consequences, including gender-based violence. So when we talk about how we deploy condoms, as part of a condom program, as opposed to just condom distribution, we have to ensure availability, acceptability, and accessibility, right? It should be as easy to find, as demedicalized as possible, because one of the things that we know very well, if someone has to think about asking someone for a condom, they're just not going to, because they may feel ashamed, they may be concerned about getting a disapproving look from the clinician. Even, again, the clinicians and social workers who are here will know that just the act of going to a pharmacy or a place of business and asking for a condom, some people feel ashamed to do it. So it must be made as ubiquitous as possible. There needs to be a total market approach of public, private, NGO donors, all the groups we spoke about that overlap with the combination HIV prevention approach. And there must be end user involvement at all stages. So who are the priority groups that are not getting access to condoms, or where the penetration of condom use is not where we need it to be? Where is the data? Who do you need to target? And this is where the programmatic part comes to. We must be setting priorities, goals, and targets. What are we aiming to achieve with a condom distribution program? How many condoms are we looking to distribute, to whom? How are we monitoring use? Are we ensuring, something as simple as do the patients we serve know to use a condom? And that sounds like a surprising question, but I've had it on more than one occasion where I've asked someone, do they know how to use a condom? Yes, okay, show me. And, for example, they describe it and they just have been using it wrong all the time. And it's important as well to create demand for condoms, right? And to promote condom use in both again in our own individual areas of influence as well as part of the broader society. This shouldn't be something shameful about getting condoms. So in terms of what some of the recent updates have been with respect to some of the biomedical prevention aspects. So I want to talk about pre-exposure prophylaxis, not because it's new, but because it impinges on the rest of the conversation. So WHO would have first made a recommendation for pre-exposure prophylaxis in 2016, where the recommendation that a tenofovir-containing regimen be offered as additional prevention as part of a combination prevention approach. And in over the ensuing few years, they would have also included the event-driven pre-exposure prophylaxis. So in 2016, what we were talking about was taking pre-exposure prophylaxis every day, which is tenofovir or Mrftt tenofovir every day as part of a prevention method. In 2019, when the data came in that event-driven, which I'll speak to the next slide, pre-exposure prophylaxis had similar rates of prevention among a certain population, then they expanded the recommendation to suit. One of the questions that has evolved over time is, what do we mean by a population at significant risk of HIV acquisition? Now, initially in 2016, there was a very specific meaning. It meant a population in whom there was a HIV incident rate of at least greater than 3 per 100 patients a year. And those groups were men of sex with men, transgender women, and heterosexual men or women with either partners of who have undiagnosed HIV or untreated HIV, who has therefore a substantial risk of acquiring HIV. But over time, that definition softened to a certain extent because, for example, there may be a group that doesn't fall into that substantial, so a person in that group, that doesn't fall into that substantial risk of HIV acquisition, but yet because of their own individual behavior or their own individual exposure, is at a higher risk of acquiring HIV and therefore should qualify for pre-exposure prophylaxis. So essentially what the WHO is saying is that it should be on a case-by-case basis. If someone is asking for PrEP, they know why they're asking for PrEP and give us them whether or not you think they're part of the right demographic group and that sort of thing, right? And with respect to PrEP effectiveness, that entire little image on the right essentially illustrates, despite the fact that there have been varying calculations regarding the effectiveness of pre-exposure prophylaxis, the reasons for those variations is adherence to treatment. So once persons take the medication, they have north of 80% risk reduction in acquiring HIV. Some of the earlier studies actually had suggested that pre-exposure prophylaxis was not effective, but when they did subsequent studies, they realized the reason it wasn't effective is that it wasn't being adhered to. And that's important when we come to later approaches to PrEP. And this is just what they call event-driven or on-demand PrEP, where instead of taking breast prophylaxis every day, you would take 2 pills of emtricitabine tenofovir, somewhere between 2 and 24 hours before sex, and then 1 tablet 24 hours after that, and then another tablet 24 hours after that. If there are continuing exposures during this period, you continue taking the medication until at least 48 hours after the last sexual encounter. It's important to know that this applies only to cisgender men who have sex with men. Reason being that this dosing strategy does not achieve high enough levels of antiretroviral medication in the vaginal mucosa. That takes about 7 days. So event-driven PrEP does not work for cisgender females. And additionally, tenofovir alafenamide, which is the newer version of tenofovir, has been studied, but there is as yet, it is comparable in terms of daily PrEP, but there's not yet enough data with regard to event-driven pre-exposure prophylaxis. Now, part of the concern regarding pre-exposure prophylaxis, the early studies did not show evidence of what's called risk compensation, meaning someone who is HIV negative taking pre-exposure prophylaxis changes sexual behaviors and possibly engaging in more high-risk sexual behaviors because they presume that they're infected from HIV because of their being on pre-exposure prophylaxis, but engaging behaviors that raise their chance of getting other STIs for syphilis, gonorrhea. And especially this is important given the rates of drug-resistant STIs, especially gonorrhea, which is, as Dr. Edwards always said, which is our superbug, right? So those dynamics have to be balanced because subsequent studies did in fact show some evidence of risk compensation once in the open label studies or the open label portion of the studies, and when PrEP was given out more generally. And I think there were 8 studies at IES 2018 showing evidence of increased STI risk and increased risk compensation. So it becomes an issue of balance. How do you balance the possibility of rising STI rates versus the well-demonstrated fact that in large cities, especially in large urban centers where pre-exposure prophylaxis was rolled out, you were able to demonstrate significant reductions, double-digit reductions in HIV incidence over time. So this is one of the interventions that is new to the prevention section in the WHO guidelines, and is something called the Didactic Vagina Ring. What is it? So it is essentially, the Ring is a non-nucleoside, reverse transcriptase inhibitor, which is embedded in a silicone ring and inserted into the vagina. And the drug, very little is absorbed systemically. Its action is entirely local, and it has been shown to reduce risk of HIV acquisition by 29% in some meta-analyses. It can go into the middle to high 30s based on the population under study. What they found was it is generally highly acceptable. It's female initiated because remember, we spoke very earlier about the fact that in many parts of the world, women carry a disproportionate load of new HIV infections. There have been, again, based on WHO analysis, very few instances in which having the ring in situ has had adverse consequences to the woman, especially in the context of her male partner who may have discovered the ring, for example, during sex or during foreplay. And in the context of non-disclosure, there have thankfully been very relatively few adverse outcomes as a result of that. There is no greater risk of drug-resistant HIV infection as a result of having the Vagina Ring placed in. And in terms of how feasible it is for countries like ours, it would depend to a large extent on cost effectiveness of the intervention, how acceptable it is in local context, because it is relatively $7 US, I think it was the figure quoted in WHO documents, which is still relatively expensive, right, if you're rolling this out on a population-wide level. And it will also be based on the HIV and local HIV epidemiology, because if the large burden of transmission in the place where this is rolled out, it is not carried by cisgender women, then it may not have the same level of impact as it would have in countries, for example, where the reverse is true. We will speak, I think, so this kit was presented at, I think, one of the prevention meetings earlier on in the year. Injectable Carbohydrate River. So what is Carbohydrate River? It belongs to a class of integrase inhibitors and has a very long half-life when given intramuscularly. Now, it would have been studied previously as treatment in combination with another drug called Ripivirine in persons with HIV who are already suppressed and who are switching from oral medication to injectable medication. And this was the Atlas and the Atlas 2M studies, where you either get an injection every month or every 2 months. And in both those trials, it was found to be non-inferior to continuing with daily medication. So the 2 trials that were done with Carbohydrate River was HPTN 083 and 084. In 083, it was twice monthly injections of Carbohydrate River as pre-exposure prophylaxis among men of sex with men and transgender women. And in 084, again, not twice monthly, every 2-month injections of Carbohydrate River in cisgender women. And I think this is very commendable, because one of the really knocks on a lot of drug trials that they do not include enough women. So for example, I can't remember exactly which drug it was, but it was one of the drugs that was being studied for pre-exposure prophylaxis. No women were included as part of the trial. So when it came time to make a recommendation with respect to can this drug be used and in which population, because there was an absence of data in cisgender women, no statement could be made. So it was very important that moving forward, regardless of the intervention, that we include women in these studies, so we can actually make evidence-based recommendations regarding prevention moving forward. So with respect to the study design, it was a randomized double-blind phase 2B/3 trial. In the first 4 weeks, the person in the trial would receive oral Carbohydrate River or placebo, and the comparator group would receive oral Mrftt every day, which is standard pre-exposure prophylaxis. At the end of the 4th week and the beginning of the 5th week, then they'll receive twice monthly injections of Carbohydrate River 600 milligrams, or continue on their Mrftt as pre-exposure prophylaxis for the next 3 years. And then at the end of that 3-year period, they would switch off of the Carbohydrate River, and all parties will continue Mrftt. Reason being that because the half-life of Carbohydrate River is so long, if you were to just stop the Carbohydrate River injections and not have coverage with that nucleoside backbone, you would eventually get Carbohydrate River levels dipping to the point where they're no longer protective, and there was a possibility that persons get breakthrough infections, and we may show some of this as we go forward, with drug resistance as the levels started to wane. Now, in terms of how the breakthrough infections were classified, so they were classified in 4 groups. So group A would be a person who had an HIV positive test at enrollment who was not discovered until later on. Group B was someone who would have become infected with HIV despite not having, after not having any Carbohydrate River at all. Group C would have been infected during the initial 4-week period, and Group D would have been persons who were infected despite having on-time Carbohydrate River infections and what injections are and what they found. And there's a kind of complicated slide, but essentially what it means is that only 4 of the 12 new cases of HIV infection that occurred in persons who were on cabotegravir occurred in persons who were properly taking the cabotegravir on time, which is D1 through D4. So at the bottom of that picture, right? In the top 3 would have been persons who would have been infected prior to beginning in beginning the study. So they would have been not failures of treatment per se. In several of the others would have been persons who would have gotten infected prior to the onset of cabotegravir, and the third group would have been persons who were infected after, for example, poor adherence either to oral cabotegravir or to the injection cabotegravir. So in terms of actual failure of cabotegravir IM, it's really only 4 to the 12. So essentially, in the standard arm, in persons who were taking emtricitabine and tenofovir, there were 39 new infections versus 12 in persons who were taking injectable cabotegravir, in which was a 30% chance of acquiring HIV on cabotegravir versus emtricitabine and tenofovir. So in other words, the cabotegravir was superior to emtricitabine and tenofovir as post-exposure prophylaxis. What was important at the end of the trial, they realized that in persons who were on cabotegravir who had breakthrough infections, they found that they did not test antibody positive for a prolonged period of time. And this may be due to the fact that you may have some amount of cabotegravir still in the system, suppressing viral replication and suppressing cell conversion, which is important because it means that your standard testing algorithms no longer hold true, and you will find people who have breakthrough infections on cabotegravir for a long period of time. And the most accurate way of detecting these infections would be to do a PCR or viral load, but that's potentially problematic, especially in countries. I'll go to the next slide on this. In countries where they don't have good access to viral platforms, viral machines. They're still struggling to get viral testing done for people living with HIV. If you're shifting resources to diagnose persons who are circumventing on cabotegravir, should, let's say, at some point in time this become a global, worldwide thing, and there's strong reasons to think it's highly effective. It's one injection every 2 months. You don't have to worry about people forgetting to take their pills. Adherence is improved. It's superior to the standard of care. But if the monitoring is not available, what we wind up doing is having persons getting breakthrough infection and not detecting them in time. And then they develop integrase resistance while on this regimen. So HBTN 084, which is again in cisgender women, a similar study design. You get oral medications for 4 weeks. And you start the 5th week, you would start getting injections every 2 months, and then everyone shifts off to oral medications after the end of 185 weeks. And in terms of how cabotegravir performed, there were only 4 seroconversions out of 1,600 patients on cabotegravir versus 36 in seroconversions in persons who are on tenofovir and emtricitabine. So there was an overall 89% lower risk of infection in women on cabotegravir. And the safety data was excellent. Women got pregnant while on without any significantly higher rate of adverse events. So both for cisgender men have sex with men, transgender women, cisgender women, cabotegravir has shown itself to be very efficacious. But again, in terms of the thing we spoke about, access, availability, and affordability, will low and middle income countries ever see the benefits of drugs like these? Primarily because of cost. Secondly, we have to think about, is this going to move prevention back? We try to demedicalize and decentralize. Is this going to do the reverse? Because now you have to come in somewhere to get an injection under the care of someone who's trained. most likely a doctor or a nurse. And is that going to run us right back in the same structural barriers we're trying to escape in terms of broadening access to HIV preventive services? And again, the issue with respect to delayed detection of breakthrough HIV infection, and the possibility for PCR testing, how are we going to manage that in non-middle income countries who have limited access to viral testing that's so important in treatment? So I'm going to, this is probably the last slide I'm going to talk about, is Latrover, which is a first-in-class nucleoside reverse transcriptase translocation inhibitor, which is a bit of a mouthful, but it's essentially it acts against reverse transcriptase in HIV. It has a high potency and a long half-life, even with oral dosing, which is tremendous. And there is a recent study showing that taking once monthly oral doses of Latrover at a dose of, I think, 60 milligrams a day, if I'm correct, 60 or 120, was shown to have acceptable pharmacokinetic levels. In other words, the drug levels were high enough that it was able to maintain, we expected to maintain suppression or prevention of HIV infection with once monthly dosing. And there are other approaches that would be that are under study right now. For example, it seems to have subdermal patch that is sometimes used for contraception. They're studying both Latrover and Carbohydrate for that application of preventive services. So, for example, a woman coming in for sexual and reproductive health treatment and who's coming in for contraception can get an injection of one of these new agents as pre-exposure prophylaxis to reduce the chance of getting HIV as well. So we have to talk a little bit about COVID because it has had significant impact on prevention efforts all around the world, because when COVID hit, a lot of prevention programs got scuttled or shut down or cannibalized because of the shortage of resources. In terms of the impact on the economic capability of persons even to have access to those services. For example, if you had to go somewhere to get these services, how are you going to get there if you were just not able to? And in addition, treatment access has slowed down. So I didn't include the graphic, but many countries around the world, when COVID hit, got supply chain interruptions with their antiretroviral medications. And we were no strangers to this either, because we had stockouts in the first half of the year that significantly impacted access to multiple antiretrovirals. I mean, thankfully, we were able to switch and move stuff around, but even that activity caused persons to interrupt treatment with side effects or nervousness about this new medication or different pill burden, and it had a significant impact on our ability to manage our patients well. And when we talk about uricose U, which I didn't speak about because, again, it's for limitations of time, but if we're talking about uricose U, and we're talking about continuous treatment access, and COVID is disrupting those, then it's having a sort of whole system impact on prevention, whether it's the combination prevention we're talking about or treatment as prevention. So just by way of summary, over 1.5 million persons are infected with HIV every year. And ending the pandemic requires that we deploy combination approaches to prevention that are accessible, acceptable, and available. And tailoring each intervention to our own local context is essential to ensure both sustainability and effectiveness of our prevention efforts and our prevention response. So that is the end of my presentation. I thank you very much. If anyone has any questions, please feel free to ask. All right, is everyone fine with the presentation so far? Yes. So. All right. But if you can't unmute where you are, feel free to type into.
Hi,
Right.
Dr. Boyce. Hi.
Uh,
I have a question. Could you
yeah,
explain more a little bit on the ring? I saw you had like I came in late a little bit with the ring
right,
part of the prevention method for women. Could you just explain that a little bit for me?
right. So it's called a dapivirine. That's the name of the drug, dapivirine vaginal ring. So dapivirine is a drug in the same class as, let's say, efavirenz or nevirapine, right? So a non-nucleoside reverse transcriptase inhibitor. So it's embedded in that silicone ring, and the ring is inserted intravaginally and has to be changed every month, right? Now, protection doesn't begin until roughly 24 hours after the ring is inserted because it diffuses into the surrounding vaginal tissue and prevents HIV acquisition, right? The extent of protection, the risk reduction is around 30% in women, which is why it's recommended to be part of a combination approach, including condoms, possibly including pre-exposure prophylaxis. And in some countries where both technologies are available, some women will combine PrEP, let's say with PrEP tablets and intermittent plus the vaginal ring, even though there's not the data to suggest that additively they carry an increased benefit, but I think over time we'll get some of that data coming in. So because it's female initiated, you don't have to wait for your partner to put on a condom. You don't have to wait for your partner to agree to putting on a condom, right? So the woman has a greater level of control over her own protection from HIV. And it's generally well accepted. They have fairly high acceptance rates, except in some of these studies, women under the age of 25 did not fare as well in terms of the extent of their protection, was as low as 10%, because they didn't accept it well. They weren't adhering to it very well, right? So in women over the age of 25, they had a rate that sometimes went as high as 60-odd%, because yes, accepting technology better. So it was added at the last update of the WHO consolidated guidelines in July, to the prevention section, right? Because WHO is now recommending this as part of a combination prevention strategy to reduce the risk of HIV acquisition from cisgender women.
Okay, thanks very much. But but you may or may not know, but would this be able to be used for transgender men, transgender women who have done the surgery?
So difficult to say, because these studies would have been done primarily not primarily, so it would have been done in cisgender women. So it would be difficult to say from a standpoint of actual data, how well it would work, right? Because the anatomy would be different, right? In transgender men who have not had gender reassignment surgery as yet, who still have their genital tract intact, I would expect, given that the anatomy is not different, that the outcomes would not be different, right? But that's in transgender men. In transgender women, it's the anatomy is different. So it would have to be specifically studied in that population to make any determination.
Thank you so much for that.
Question from Palace: prevention possibly available in Trinidad, and if not, is there a timeline for when it may become available? To my knowledge, no. I mean, I could be wrong, but I haven't seen it discussed. I don't know if you might know, if you know more than your family. Have you heard about any discussion about having it available at family planning at all? I don't know if you heard me. All right.
Sorry?
So I know you're at family planning. Connor was asking if the ring is available in Trinidad. And to my knowledge, the answer is no. But I don't know if you have heard anything at family planning about if it's available or not.
No, I haven't heard anything. But I will ask because that is quite interesting. But the thing, what I would also like to know, if it is or if we can, does it need, does our health ministry need to approve it just like how they have to approve practice Khabib? Because I don't know if they would consider that a drug as well. And we all know the health minister stand on prep.
Right. So So technically, it's a form of exposure prophylaxis because it is a medication in a way that you take to prevent HIV acquisition, except it's inserted intravaginally, and its effects are local. It's not, it is not much absorption into the rest of the body, right? So its effects are just within that area. I suspect it would have to be approved, right? Because it's a medication containing device. Yeah, it's difficult to think that it could just be brought in without some sort of food and drug sort of approval.
Yeah, I would think it would be sooner. So, let's hope he gets on board.
Still from Leona Mari. Thinking about the recent highlights on stealthing in the United States, I feel if a study on this topic needs to be implemented locally before it becomes popular if it isn't already. So stealthing I suspect everyone in the room knows what stealthing is, but just by way of explanation, stealthing is activity where, for example, a man having sex with a woman and without her knowledge or consent removes the condom, right? And continues to have intercourse with her. Now, I know at least one state, possibly more than one, has made this a crime because you are robbing the woman of consent. Because when the acts occurred, the consent was based on you have a condom. If you change that during the act without the knowledge of the woman, it is essentially a form of sexual assault, right? So I know from my own experience that does happen in Trinidad. I mean, of course, it happens everywhere. Whether or not it needs to be criminalized, I'm not sure. There was a very elegant write-up on it. For this, I mean, that's the sort of principles. You know, when someone consents to sex, what is the extent of that, right? And anything that violates that consent is assault, right? If you know, I remember that video about where they were talking about sexual assault and tea. You know, if the person doesn't agree to tea, don't pour tea down their throat. Right? It's the same sort of thing. If I didn't agree to this is assault. Right. Okay. So we just have about 10 minutes. I don't know. We can progress to the case very briefly.